Hey everyone, and welcome to this high-yield explainer. If you're currently prepping for your medical boards, you already know that endocrine syndromes can be an absolute maze. You're dealing with seemingly identical acronyms, overlapping symptoms, and of course, those highly testable genetic markers. Well, today, we're bringing absolute clarity to one of the most frequently tested topics in all of endocrinology. We're going to completely master the fundamental differences between MEN1 and MEN2.
So, do you constantly mix up MN1 and MN2 on your high-stakes practice exams? Trust me, you are definitely not alone on this. It is so incredibly common to stare at a clinical vignette, pull your hair out, and second-guess whether that parathyroid issue is pointing to Warmer syndrome or Sippel syndrome. The sheer volume of information is just overwhelming. Okay, let's dive into this right now and build a mental framework that you will literally never forget.
Here's a quick look at our roadmap. We'll start with the shared ground. Neatly unpack MN1 and MN2. Put their genetics in a head-to-head showdown, and finally synthesize the whole shebang into an ultimate exam review table. Let's get to it.
Act 1. The shared ground. Before we get into what makes these syndromes different, we really need to understand the foundational rules of the game. So what are we actually dealing with here? Multiple endocrine neoplasia, or MEN, is basically defined as a predilection for tumors involving two or more endocrine glands. But the thing you absolutely need to lock in right now is the inheritance pattern. They are inherited in an autosomal dominant pattern, and they have variable penetrance. To put that simply, if a patient has the genetic mutation, it's a genetic coin flip, a 50% chance that they'll pass it to their kids. However, because of that variable penetrance, exactly which tumors pop up and when they appear can vary wildly from person to person.
Act 2. Unpacking MEN1, which historically goes by Warmer syndrome. Let's isolate this specific disease process.
The precise mechanics here are actually pretty fascinating. MEN1 is caused by mutations in the MEN1 gene, which hangs out on chromosome 11q13. This gene encodes a 610 amino acid protein called menin. Now, here is your key takeaway. Menin is a tumor suppressor. Its whole job is to regulate transcription and keep the genome stable. Following Knudson's famous two-hit hypothesis, a patient inherits one defective copy of the gene, right? Then when a somatic mutation comes along later and knocks out the second normal copy, that's when the tumor starts to grow.
Okay, so what tumors actually grow once that happens? You gotta burn this PPP triad into your memory. When you see MEN1, immediately think of the three Ps: parathyroid tumors, pancreatic neuroendocrine tumors, and pituitary tumors. If a clinical vignette gives you a patient who, say, has kidney stones from hypercalcemia, a bad history of stomach ulcers, and maybe some visual field defects, your brain should instantly flash MEN1. No hesitation.
90%. That is massive, guys. That's the frequency of primary hyperparathyroidism in MEN1 patients. It is far and away the most common feature of the syndrome. But here's the critical exam distinction. Sporadic hyperparathyroidism usually affects older women and involves just a single adenoma. MEN1 hyperparathyroidism is totally different. It hits patients when they're young, like 20 to 25 years old, with an equal male to female ratio. Plus, it almost always affects all four of the parathyroid glands. Because of that, a quick, minimally invasive surgery just isn't going to cut it. These patients require a subtotal parathyroidectomy.
Let's pause for a massive previous year question alert, because this specific distinction trips up test takers every single year. A gastronoma, which drives Zollinger-Ellison syndrome with those brutal recurrent peptic ulcers, is the most common functional pancreatic net in MEN1. But if the board question asks you for the most common pancreatic net overall in MEN1, the answer shifts. It's a non-functioning tumor. Read the question super carefully, okay? Functional versus overall. Don't let them trick you. Moving on to Act 3, exploring MEN2, which encompasses both 2A and 2B. Time to wipe the slate clean, because the pathology we're looking at now is entirely different.
MEN2 is driven by the RET gene, located on chromosome 10q11.2. But check out this crucial detail. RET is a proto-oncogene. We're no longer talking about losing a tumor suppressor like we were in MEN1. We are talking about an activating mutation. This gene codes for a tyrosine kinase receptor. When it mutates, it essentially gets jammed in the on position. This drives unchecked cellular proliferation, and that invariably leads to medullary thyroid carcinoma, or MTC.
So, the crucial point is 100%. MTC occurs in virtually 100% of individuals affected by MEN2. It's basically a guarantee. Whether you're looking at MEN2A or MEN2B, MTC is the most common feature across the board. Now,
This cancer arises from the C cells of the thyroid and secretes calcitonin. That calcitonin is super helpful for us because it acts as a diagnostic marker, and we can also use it to monitor the patient's prognosis just by tracking its doubling time.
Now, how do we actually tell MEN2A and 2B apart on a tricky exam question? Well, both of them have MTC, right? And both of them carry a roughly 50% chance of developing adrenal pheochromocytomas. Here is your critical dividing line. MEN2A features hyperparathyroidism in about 20 to 25% of cases. MEN2B, on the other hand, does not have hyperparathyroidism. Instead, MEN2B presents with mucosal neuromas on the lips and tongue, alongside a tall, lanky, marfanoid body habitus. If you see a marfanoid patient with thyroid cancer in a question stem, boom, you instantly click MEN2B and move on.
Here's another previous year question alert, and this one translates into an absolutely life-saving clinical pearl. Always exclude a pheochromocytoma before you even think about performing a thyroidectomy in an MEN2 patient. Why? Well, if you wheel a patient into the OR to take out their thyroid, and they happen to have an undiagnosed pheo sitting there, the stress of the anesthesia and the surgery itself will trigger a massive, sudden release of catecholamines. That's going to lead to an intraoperative hypertensive crisis, which can be rapidly fatal. Rule out the pheo first. Always, always, always.
Act 4. Genetics and tumor contrast. Let's put these two overarching syndromes into a direct head-to-head showdown. And this brilliantly illustrates the core divergence we've been building towards. MEN1 relies on the MEN1 gene on chromosome 11q13 to produce the menin protein, and the disease only kicks in when you have the loss of that tumor suppressor. So it's a loss-of-function disease. In sharp contrast, MEN2 relies on the RET gene on chromosome 10q11.2, and that disease is caused by proto-oncogene activation. It's a gain-of-function disease. Understanding this core mechanism is absolutely crucial because it dictates exactly how aggressive these tumors are going to be.
And speaking of aggressiveness, let's talk about the specific RET mutations. The physical location of the mutation on the gene, the specific codon, actually dictates the timeline for when we need to do a prophylactic thyroidectomy to prevent metastatic medullary thyroid cancer. For instance, a mutation at codon 918 is characteristic of MEN2B. This is the highest risk category out there. It causes the most aggressive MTC, which means these babies require a thyroidectomy within the first 6 months of life. Meanwhile, a mutation at codon 634 is the most common MEN2A mutation. It's still high risk, for sure, but allows us to perform the thyroidectomy slightly later, usually before the age of 5.
Act 5. The ultimate exam review table. We've gone over all the individual pieces, and now it's time for the master synthesis.
Seriously, if you take one thing away from this explainer, make it a mental screenshot of this summary right here. Let's read across. MEN1 is driven by the ME1 tumor suppressor gene, and it's marked by that classic PPP triad: parathyroid, pancreatic, and pituitary tumors. MEN2A is driven by the RET proto-oncogene, presenting with medullary thyroid carcinoma, pheochromocytoma, and hyperparathyroidism. Finally, MEN2B is specifically driven by the RET codon 918 mutation, featuring that highly aggressive MTC, pheochromocytoma, and those distinct physical signs, the mucosal neuromas and a marfanoid habitus, notably without the hyperparathyroidism we just saw in 2A. Keep coming back to this contrast table. It is literally your ultimate medical exam review tool.
Okay, before we wrap this up, I want to leave you with a provocative thought to test your newly solidified knowledge. About 5 to 10% of MEN2 patients actually have a de novo, or entirely new, RET mutation, which almost always occurs on the paternal allele. So, knowing what we just discussed about genetic inheritance and codon aggressiveness, if a patient presents with that kind of mutation, what specific clinical screening should their children face, and at what exact age should that screening begin? Think about this specific mutation codon and that strict timeline for prophylactic surgery. Keep studying hard, trust the framework you built today, and you are going to absolutely crush your exams. Catch you next time.